All right, it's 4:30, so thank you all very much for joining us for our board meeting. We are officially called to order. And unless there are any additions, deletions, or corrections of our minutes, both for the executive committee meeting and our last board meeting, we will assume that they are approved as presented. Is there any objection or any changes? Thank you. Let's go right to resolution, Dr. Cummings on medical dental staff meeting. Mike?
I do not know if he is on yet, sir.
Well, we'll delay that one until he gets on, or
There
Brian,
he is.
are you
Right, he
prepared
just
to?
got on.
Oh,
Yep.
Dr. Cummings?
Hello, how are you today?
I'm good, thank you. The medical staff, medical dental staff meeting minutes, we good to go?
We are good to go, yep.
No issues, concerns?
No, I'm sorry, yep, yeah, there is no issues, and the medical staff meeting went very well yesterday with no issues or extractions, as did the credentials committee as well.
Great, thank you, Dr. Cummings. Motion's been made by Dr. Cummings. Is there a second?
Second.
Second, any further discussion? All in favor, please signify by saying aye.
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 And to the contrary, that motion carries. Thank you, Dr. Cummings. Dr. Quattrochi, you've been busy today.
It's been a little busy. Jeffrey, in my presentation. Hello,
Yeah.
everybody. Okay. So I just want to obviously keep you updated as to where we are with our COVID patients. Good news is we are seeing the number of COVID patients that we're treating reducing. We actually have 44 COVID patients in the house today. We have been running about 60 COVID patients. We went down a little slower than the community, the other hospitals in the community, because we have behavioral health patients who come in for behavioral health issues and are testing positive. So we kind of declined a little slower. The good news is that we're continuing to see a lower length of stay than we saw in the summer, although it's ticked up a little bit, and less patients vented. And you can see the amount of testing that we've done to date. Next slide. These are the vaccinations we've done to date. You can see we have obviously our ECMC employees with the first dose, and the amount of employees, some employees are still to be scheduled for the second doses. The community doses that we've administered, those are really to frontline healthcare workers. And obviously we're continuing to do the second doses for those folks too. Next slide. Hospital acquired infections. Again, we continue to monitor our hospital acquired infections. You can see our goals for this year for both central line and catheter associated hospital infections. And we'll just continue to keep the board obviously updated because our goal is to be at 0. Next slide. Oh, go backwards there, Jeffrey. We had a really good presentation in QI around from Dr. Crane around the COVID-19 pandemic. And I'd just like Dr. Murray just to take a second and talk about what we had done with regard to some clinical trials and the fact that we actually saw a high percentage, as you can see, of African-American individuals enrolled in these clinical trials because of their trust, community's trust with ECMC. So Dr. Murray, if you could just really quickly just talk about that presentation in this slide, please.
Sure. You know, obviously the response to the COVID-19 pandemic was really a multidisciplinary approach, and we had input from many departments. But obviously the infectious disease group were front and foremost, particularly in the early days, trying to determine what would be viable treatments. And the other thing was that we did get involved through a UB consortium. We did get an opportunity to do some clinical trials. The major one we did was in an IL-6 antagonist, sarilumab. And one of the remarkable things about this was that of all the subjects we enrolled, 80% were African American. And that's very, very unusual in clinical trials. Minority groups are generally underrepresented. And, you know, when we talked to Dr. Crane about this and why he was so successful in that regard, it seemed to be because the patients basically trusted their doctors in the hospital, that they were, and relied on their advice. And we're hoping this will carry over too into the vaccine initiative, you know, that where obviously there have been challenges because of access and hesitancy in terms of assessing the vaccine. So not only Dr. Crane's effort in research, but Dr. Klaus in particular, who was really instrumental in setting up the COVID-19 testing for the community in the parking lot. In fact, Dr. Klaus was performing most of the nasal swabs in the early days himself personally. And the contributions of these individuals were just invaluable, and you know, certainly develop a merit mention here. And I know Mike Hoffert heard the whole presentation here at Board PI and was very impressed, and wanted the board to see it also.
Great, thank you, Dr. Murray. Any questions, Dr. Murray? Okay, next slide. We were recognized again by NCQA, the Patient Centered Medical Home, which really measures quality for internal medicine and family health center through technology and a holistic approach to treating the patient. It's a national recognition, and we're just very proud of our internal medicine and family health center. Next slide. Our BRAVE program, we see the 2021 New York State Chapter American Trauma Society Small Projects Fund, and you can see some of the things that we received for domestic violence and injury prevention. Next slide. These are some of the awards that folks in the organization have won. I always like to point that out to the board to let you know that we continue to recognize our ECMC family. We're spearheading the nursing department spearheading a new initiative. It's called the Tulip Award. You know about the Daisy Award, of course, but we're going to do a new award for team members who provide exceptional care that are not nurses. So it's going to be open to all departments. So it would be dietary to environmental services, you name it, and a new recognition for our ECMC family. So thank you to Karen Zemansky and Andy Davis and others who worked on this or worked to make this happen. And again, some more recognitions from some of our ECMC family. Next slide. Yeah, go ahead, Mike.
Yeah, I would just like for in the future, you know, in the past, it was nice when we were in the boardroom and, you know, Karen brought a lot of these nurses in, we got to recognize them. And, you know, if we got to see them throughout the hospital, we could recognize them. In the future, could we just even include their pictures? Because, you know, I truly appreciate these folks as a board member, and I kind of miss not being able to see them. You know, I used to go up and congratulate them in person and that kind of thing. But hopefully when we get back to normal, you know, I'll be seeing them in the hospital and I can thank them for their contributions.
Yeah, I definitely will do that. And I know many of you on the call frequent ECMC, so I'll make sure we put pictures up there for the future.
That's a good point, Mike. Thank you.
Yeah, thank you.
Thank you.
Patient experience scores. We continue to monitor our patient experience scores through COVID across the country. Patient experience scores dipped. Obviously, we were overwhelmed at one point with patients, and as a result, we saw that we weren't able to respond as quickly as we normally like to. So we have a lot of initiatives this year for patient experience and making sure that we continue to work by the bedside to deliver good patient care, but a good patient experience. And so you'll hopefully continue to see these scores rise, but again, this is we continue to be, you know, at or above the New York State averages. I showed that in the annual meeting. but we want to continue to make sure we see these scores increase. Next slide. A couple things we did over Valentine's Day. We did a patient flower distribution. We do that every year. We weren't able to do it the way we typically like to do it, where the executive team goes to each of the floors, but we were able to do that, distribute those flowers. Next slide. We're celebrating Black History Month in the month of February, and I just wanted to point out we had a virtual celebration. We have a kind of a closing webinar that Andy and I are going to participate in coming up. But we feature some guest speakers. Dr. Juanita Hunter, if you remember, she was actually in the 100th anniversary video as a head nurse from E.J. Meyer Memorial Hospital, to a lot of great stories about back then. And then Pam Riley, who was unit manager here for many, many years, as well as Sonia Melvin, talked at again, a webinar.
Pam Riley was up in palliative care, was she not?
Karen, what floors was she responsible for?
She was responsible for 12 Zone 2, which was a medical surgical unit.
So she might have had some responsibility over some of the nurses, John, in that area. Obviously, also for Black History Month, Peter, remind me of the exact phrasing of the colors. It's pan.
Those are the Pan-African colors. They're typically red, black, green, and yellow. We had a little bit of a challenge with black so people could see it. So we made that sea as dark as we could so that it would be visible for everybody to view it.
So obviously we did a lot of internal awareness around that to show the organization our commitment to Black History Month. And obviously as of this past year, the awakening that we had around racism and injustice. Next slide. Continue to have some music, brought some music back into the building. We haven't had that in a while, so it was nice to have that in the organization. TICU Beacon Award. Again, I mentioned this last meeting, but we had a celebration in TICU. We got an opportunity to talk to the staff and recognize them for this award. They joined, as you know, the burn unit and the MICU for this national award. Next slide. We're celebrating Bank of Resident Week. So we are celebrating our residents. The university was obviously very happy that we were doing this. As I said to some of the physicians who may be a little more seasoned, I'm sure they would have liked to have been thanked when they were a resident. But obviously we want to make sure we recognize our residents. They're part of our ECMC family and provide an invaluable service as they learn here at ECMC. Next slide. In our behavioral health unit, we had an initiative to bring some art to that area. And Karen, if you could just talk real quick about this initiative. It's really a cool initiative because it was kind of from the ground up. And as you can see, we had one of our RN charge nurses paint this mural.
Yes, it was very exciting. This is a Pathway to Excellence moment for Krystal Ketter-Frankin. Her love for the adolescent population, due to the fact with lethality, we've had to take pictures down, clocks down, and other items. It really leaves the environment very bare. So she actually, who is an artist, thank you, Mike. She's an artist. She actually worked on this, and the kids voted on what they wanted as the mural, and it was really very nice. And then in CPAP, we actually are going to have former patients come in, and they're going to complete a mural, and that is in the works right now.
Great. Thank you very much, Karen.
Karen, that is spectacular. Maybe we could have them do some other stuff in the other parts of the hospital.
Yep, you're right. They probably would. We have a lot of very, very talented individuals here.
And we can finally get some art on the walls. That would be wonderful.
Thank you, Karen. Virtual town hall for vaccines. We have Dr. Cloud, Dr. Martinez, field questions, and over 100 participants joined the town hall meeting. So again, talking to our workers about the importance of getting vaccinated. As you can see, we've had a good amount of our ECMC family get vaccinated. but we still have about 30% of our employees who we want to see get vaccinated. Elective surgery resumed, as you know, on 125. We also had the appointment of a new transplant surgeon here at ECMC. I wanted to make sure you had the opportunity to see that. Real quick, our window project is on hold right now. We've had an unbelievably busy few months, and our census is higher than I've seen it in a long time. So we did put that project on hold, plus we have to meet the state requirements for surge. So we will be coming back to the board in the next couple months with regards to the status of that project and working with our vendor and how we can make sure that we obviously complete it. We put them on hold a few times during this pandemic to make sure that we don't take any rooms offline, because we have to do a whole row all at once when we do it. But there is more to come on that. And then just real quick, in dietary, we have a new tray line that we're going to be working with Mets to install. The tray line is original to the building, I believe. So that's going to be important as we improve our dietary service. And then we also started limited patient visitation on 2/4 this past month.
Tom, that's one visitor per patient?
Yes, one visitor per patient, and we do allow more for compassionate care. 2021 year-to-date statistics for this through this month of January. You can see, obviously, because of the lack of surgeries, I don't think there's anything surprising here. And obviously, our observation cases continues to go down, but our statistics this month are obviously a lot better. We're at right now, as of today, we're about even where we need to be with budget. So that's good news. But we'll continue to keep the board updated. And you can see our outpatient visits are up, but included in that number is also the COVID-related initiatives that we do. So with that, if there's any questions, happy to answer them at this time.
Thank you, Tom. Before we go to John, I mentioned earlier, Tom was up early this morning and did a presentation to the board of directors of the Buffalo Niagara Partnership, which, as some of you know, is the business leadership across Western New York. And Tom did his usual great job. But Tom, I've been getting text messages all morning and afternoon about the job that you have done on behalf of the community. So thank you. And I think the board needs to know that the issues that we have been facing, Tom has shared in a very important way, and as I say, was very well received. So thanks again.
Thanks, John.
John Swy, please.
Yes. Okay. Thank you. Jeffrey, you can stay right on this slide for a few minutes. And as Tom said, we have been busy recently, but what did impact us specifically during the month of January was the restrictions that were put in place on December 4th. Those really lasted about 16 business days, or through January 25th. And so that was about 3.5 weeks of time during the month of January that we were not able to do certain procedures. And you can see it really showing up here on the operating statistics with 14% fewer inpatient discharges, as well as when you look at the surgical procedures down below, which it's much more pronounced, obviously. And you can see here 37.7% below plan on inpatient and 53% below on outpatient. And when we flip to the next slide, which is the dashboard that we'd like to show you, it's our finance dashboard. That really did play the majority of the impact, and it was the primary driver of the overall operating performance of a loss of about $7.9 million for the month. Just to give you a quick refresher on our budget, our overall budget for the year is roughly a loss of $29 million. And so for the month of January, we had budgeted about $2.8 million of loss. So we're off plan by about 5.2, again, driven largely by the lost revenue. But just to highlight a couple of the other items on here, I think it's important to note that with the fewer discharges and fewer inpatient surgeries that we did see, it really did have an impact on our case severity. So our case mix index was below plan. But also, when you take those elective type surgeries that typically don't have a long length of stay out of the actual side, you start to see an increase in that length of stay. We also did an increase early in the month of length of stay related to COVID, but that has since been coming down, as Tom has mentioned. I did want to highlight two things on here also. Our FTEs, we're remaining right around the 3,500 mark. It's in yellow because we're not at our plan yet, but that's been somewhat by design. We've been staffing where necessary to make sure we're providing the right level of care to certainly the patients that we're seeing and the number of patients that we're seeing. The days cash on hand is higher than it was at the end of the year. And that's really driven by the good news that occurred literally the day after our last board meeting, which was our receipt of the phase 3 HHS provider relief fund dollars of about 10.5 million that we received on January 27th. So of course that was cash that was sitting in our bank account at month end.
John, what is the dollar amount of cash on hand?
It's a little over 125 million, actually.
Can you go back to the one previous slide, please? Just a question on the emergency and CPAP visits. Tom or John or Dr. Murray, can you talk to that? Those numbers are down considerably, it looks like. Yes? No?
Yeah, I mean, they're down a little bit. I think, you know, one of the issues is that when the hospital gets full, like we've had, especially with the amount of COVID patients that we've had, and you have to really view some of the COVID patients as an additional group of patients, right, than what we usually have with a very higher length of stay. It backs up the ER, and then what happens is we have a higher left without being seen number. And as Dr. Cloud will tell you, sometimes those patients aren't always ambulatory patients. Some of those patients may need to be admitted, and then they come back at a later time. You know, that's been an issue for us, is kind of the fact that we've been so busy with this higher length of stay. So I don't know if you have any other thoughts, Karen, on that, but I think that's, you know, basically the reason.
I think you summarized it. I think that we're really detailing the impact of the COVID patients. The behavioral health quarantine is automatically 10 days. So immediately we cannot meet the budget of 6.7 if it's a 10-day. Then we now have the COVID positive to COVID negative patient that has resulted in a longer length of stay due to the after effects of COVID. We now every day are reviewing that list to see if we can find those patients a post-hospital plan without going home, but is higher than what home would be. So we have our challenges with it.
Yeah, and the other thing too, John, I think there's still a certain segment of folks that aren't coming to the ER because of COVID. So I think we're still seeing those effects.
And I'm sorry if I may, from the behavioral health, this is Mike. From the behavioral health standpoint and from the CPAP visits being down, because we've been down about 9% throughout the year, I think what we're also seeing is a couple different things, but it's important to note that cases that probably never should have come to CPAP probably don't, and that's for a lot of different reasons, COVID, bail reform, et cetera, et cetera. But the cases that are coming to CPAP are the serious ones who probably should be in CPAP. And so we have not had a decrease in level of severity within our psychiatric emergency room. We've simply had a decrease in number. And some of those numbers may be attributed to people going to the help center and other things, but it's also because of the psychosocial determinants of health. Police aren't bringing people in at the rate that they were before. So that accounts for some of the decreased CPAP visits as well.
Thanks, Dr. Cummings. And of course, those numbers all correlate then to length of stay. And how did the decrease or the increase in outpatient visits then make sense? at least year over year.
Yeah, those aren't tied to the ED. You're talking about the outpatient visits?
Yes, please.
Yeah, the outpatient, that also includes our COVID-related efforts, right? So
Gotcha.
testing and those types of things. So that's why that number's a little bit higher, because it also includes those efforts.
Understood. Thank you.
Yep.
All right, John, please.
Next slide, Jeffrey. So that translates to the performance for the month that I mentioned. And you can see on this slide that the main driver is the lost revenue. So with 16 days approximately of business days without procedures, without those specific certain procedures under those restrictions, brought us to about a lost revenue number of about 5.6 million. That equates to roughly $350,000 a day, which is right around where we had anticipated it to be for the month. Overall, though, the loss of 7.9 million was somewhat mitigated by our ability to manage some of the other expenses that we were able to manage. Obviously, without procedures and with implants, you don't have the implant costs. But even with COVID-related costs that were above our plan, we were able to manage other costs, other purchased services, and IT-related
I
costs
just signed, Mary.
that we didn't need to spend. So I think from an overall perspective, we actually operated better than where we had originally anticipated the month to be going into January, given the restrictions. And from here on out, as Tom said, all those indicators that we were just talking about, whether it's length of stay, the volume, case mix, all have improved in February, and we're monitoring that as we get into the tail end of the month. And so the next slide is our summary for our COVID impact. And what I've done here is wanted to make sure the board kept a close eye on our impact, but also for the current month, but also brought forward on a cumulative basis what our total impact was and is through this date. So through January 31st, the month's impact with the lost revenue and staffing related costs, supplies, et cetera, that you see here is roughly $7.1 million for the month. But bringing forward where we were as of the December 2020 date brings us to a total of just over 104 million of total impact that we'll continue to carry this forward just to bring the frame of reference. Again, this is at a point in time, so this will change as we go forward.
John, quick question on the COVID. Do we have in process requests for support through the CARES Act in the queue at this point, or what's our status relative to getting reimbursed for any of those dollars?
Sure. So if you just, Jeffrey, maybe go to the next slide. I'll talk about it here. It is the first one here. So I'll give you an update as to where things stand. So as I said, 10.5 million we received on January 27th. That brings the total of CARES Act provider relief funds to a little over 62 million. And that covered through what they referred to as phase 3. Phase 3 was an application process that was open and started. We applied November 5th, just received the funds. They are still distributing funds related to phase 3. Where HHS is now is there is $3 billion of new money that was I'll say approved in the last coronavirus bill. There are still undistributed funds of roughly 4 billion from the last bill that I was referring to. So there's about 7 billion they have yet to distribute. There has been no, at this point, no applications open and no details on how they're going to distribute those funds. There will be another 35 billion or so in the latest proposed coronavirus stimulus bill, and the majority of which has been required to about 85%. They required that be used to fund losses for providers for the second half of 2020 and the first quarter into 2021. So at this point, no applications for the provider relief funds. However, I will say that we have filed the forgiveness application for the PPP loan, as well as we will be filing the first application for FEMA reimbursement on a subset of our potential funding there within the next week. So John, did that answer your question on the federal relief side?
Yes, thanks. Thank you, John.
Sure. Okay, just a couple other.
Just one more question. The and maybe Andy can answer this as well. Has the pressure on purchasing PPEs been any lessened now, or were the numbers still on the roof, for every glove and or gown and or face mask? We still paying,
I can answer that. It's lessened a lot. I think John and his team, led by Diane Arteria, have done a fantastic job of working with our various vendors to get good pricing on all our PPE up to date. And so we've been in pretty good shape the last 4 to 5 months with that. We haven't seen some of the things that we saw, I would say, this time a year ago.
We're still required to keep the 90-day supply though, John.
90-day supply?
And in some instances, it's higher because of the burn rates that we reported early on. So in some instances, it's triple 90 days, but we got there.
Great, thank you.
Right. Just one slide back quick, just one more thing, Jeff, sorry.
It's okay.
So since we last met, the governor has put forward the proposed executive budget. I won't go into detail here because it's still early, but just a couple of items. What we do know is that there will be Medicaid related cuts. You don't know the extent, because the extent of which really relies on how much federal funding is provided. And so that is something we'll keep the board updated on as it gets closer to March 31st here. And then just the last thing, just to reiterate, as Tom said, we're moving forward with one of our budgeted capital items, and that's the upgrade to the dietary tray line. Any questions that?
And the fourth bullet point that says eliminates public indigent care pool, what is that?
So there are indigent care pools that are, it's a mechanism through which public hospitals are paid. The way that ours works is there's a total dollar amount, and our dollars are paid either through a portion through a public indigent care pool, a portion through upper payment limit for the nursing home, and a portion through disproportionate share payments through IGT, all of which total one number. So that number doesn't change at this point for 2021. What will change is the mechanism. So for us, at this point, the way this is proposed, it would not change our overall payment. It would just change the mechanism through which it's paid.
So would it be safe to say that this is basically IGT, or is this a number in addition?
It's it is a component. It is not IGT. It's a component of the overall indigent care pool, of which IGT is also a component.
Do you know offhand how much we benefit from it, or what that number is for us?
The indigent care pool it varies each year. So, roughly $7 to $10 million on just this funding mechanism. I think really ranges.
Okay, thank you.
Any other questions that I can answer, or Andy or Tom and I can answer?
Nope. Great, John. Thank you very much. We'll move on. Finance Committee, Mike Seaman.
Don't think Mike is on.
Mike on?
Darby is on though, I think.
Building and Grounds, Mr. Bennett.
Can you hear me?
Yes.
Okay, we had a meeting today, and most projects, we had 11 projects we talked about. I think Andy's going to talk about the water situation, but it's amazing to see that 7 of those are in-house. The ability of the buildings and grounds to do these things without having to contract out and whatever the cost would be. So they were just general ideas, general things that were kept up to date. Nothing of really now that the major projects are done, but it was so good to see that the Buildings and Grounds Department worked so well to have that many, because the four that were not in-house included the exterior building, which is of course a major project. So glad to have the report.
Thank you, Ron. Mike on QI?
Yeah, I just wanted to mention, besides the infection report that was talked about earlier, Charlene had a number of reports on patient quality and care and that, and I'm just wondering if she wants to chime in with any of that.
Sure. We went through the environment of care safety plans. There's 7 of them. We went through all 7 and we looked at our 2020 goals and then compared to how we performed and then set our 2021 goals. So with that, we looked at everything from our utility management to emergency preparedness and life safety. And we've set goals for 2021 that we've already got in progress so that we can achieve these goals. And the other thing that we presented on was the national patient safety goals from the Joint Commission. There are 7 of them that we are working on currently. These are not new safety goals, but we did take a new heightened interest in a couple specific ones, one being alarms and looking at alarm fatigue within our staff and looking at the alarms we have that we are using and making sure that they are relevant and we don't have any nuisance alarms going off. So there's a team working on that very diligently, and we'll have more information on that over the next several months.
Sharon, what do you mean by alarm fatigue?
So alarm fatigue it's a national problem. It's where you have alarms going off and there's so many of them going off that you actually tune them out. So you want to make sure that your alarms are actually necessary so people don't start tuning those out. We haven't seen a problem, but we're checking every alarm we have and making sure they all have different alarm sounds and types so that there's not confusion of a critical alarm versus a less critical alarm.
Cool. Okay, thank you. Any questions for Charlene and or Mike?
I just would like to add that, I didn't realize that, we've all been in the hospital, we've all heard those alarms, but the reality of, what sound means what, the presentation was definitely eye-opening, as well as Dr. Crane's. And, Dr. Murray had mentioned earlier, Dr. Crane's report. I'm just wondering if there's any way that there's, being that the meetings are recorded, that we could, have that presentation available for everyone to view.
We can certainly check that out, and if it's available, we can certainly send it to everybody. Is it? Can we put it on a thumb drive, Dr. Murray, or put it on our website or Board Effect?
It is recorded, but I don't know how long Lisa keeps them. I'll have to reach out to her. I don't think they're, I think that particular meeting may no longer be kept. And I don't think we can't use thumb drives for security reasons, but we'd have to, probably, what we could do is probably we might be able to send a link to the board members.
Or put it on Board Effect?
Yeah, I can't check with Lisa. She's actually off this week, but I will try and reach out to her and find out if it's available.
Great, that'd be great, Dr. Murray. Thank you.
It really was a great presentation, and there was even talk that, to try and make it available to all of the board members. But as usual, they're just doing a great job. Charlene, Dr. Murray, every month they enlighten me, and they an awesome job. Thank you very much, everyone.
An enlightened Mike Hofford is almost too much to imagine.
Isn't it, John? Thank you.
Thank you, Mike. Thanks for all that you do. Before we go into executive session, 2 quick items from the executive committee. The first is Marcy and Mike Newman hosted a gift gathering on Saturday at their Anchor Bar, and Sue and Stacy did their usual spectacular job. So thank you to Mike and Marcy, and certainly Sue and Stacy. And to those of you that still want to participate, and thank you to those who have already done so, we are still, Sue would be happy to either come pick something up and or receive it online. So thank you for those who did in fact participate and for those who actually showed up. And we've talked about this probably over the past year, and that is diversity, equality, and inclusion. We have gone through a major effort in the hospital to get as many people trained as possible. We have talked about it at our board meetings. I'm with great support from Sharon Hansen, who will be leading this effort. I'm going to suggest once again that when we schedule this, which looks like March, that we need to have 100% participation from our board. So Sharon, if you would address that and what our next steps are, please. And thank you, by the way, for doing this.
Absolutely. I'm pleased to be a part of this. As many of you know, as board members, we've been taking ECMC, the employees and our processes culturally up a level almost routinely now, and including D&I in that particular program will help us to better understand what diversity and inclusion is all about, that we can involve it in our lives on a day-to-day basis. And we hope to achieve Sanpetico with all of our board members and with our employees. And we hope that our employees will recognize that the board itself is going through this training so that we can converse with them on a level that's appreciative by them. So we're looking forward to moving ahead, and I'm certainly looking forward to having all of our board members participate in it, perhaps come March. And we'll have a program and we'll have a better understanding from everyone, because most of us still in the work environment can use diversity and inclusion in our day-to-day work environments, whatever they might be. So I'm hoping that you're going to learn something new. I'm hoping that you're going to get excited about it. And I'm hoping that it's going to, again, take our cultural development inside the hospital to yet another level. That is our goal, and I look forward to sharing that with all of you.
And Sharon, once again, thank you for your leadership. Tom, would you share with everybody at least what our plan is relative to schedule and or location and or what our next steps are going to be, please?
Yes, so we'd like to have the next board meeting off-site, obviously socially distanced, and for those who want to attend virtually, you can still do that. But you know, the diversity and inclusion training really is best in person, and you know, the team is really excited to train and present to the board, because obviously your leadership is crucial and to this organization. And I know many of you, again, as I mentioned earlier, interact either being patients here or knowing many people who work here. So your leadership's critical. So we're going to try to offer a couple different times, because we know some of you, because it's closer to the holiday, may not be available in person for the next board meeting. So we're going to try to do a doodle poll and see what times you'll be available. And we'll try to evenly distribute the board so that we don't have, you know, 2 people at one meeting and the rest of the board at another. And so we'll get that information out to you and see when you're available. And as Sharon and John said, please ask that we have 100% participation, because it's an important message for our ECMC community, who's been very supportive of obviously all the D&I initiatives, as has been our union partners.
Thank you, Tom. Any other questions before we go into executive session? Okay, let's take 30 seconds to do what we need to do. And when we come back.
Tony, did you have something real quick? Sorry, Jeff.
Yes, I did, with your permission, John. I just wanted to, March is, for those of us who've gone through the cycle many times, March is a very busy board meeting month. The governance and audit committees will be working diligently on the things that they must complete before we conduct our March board meeting, which must include by way of example, the approval of our audit report, the approval of our annual report, the review and approval with no change or mandated changes of various policies. And as you may recall, we also do a board self-evaluation and a skills matrix on an annual basis. In order to accommodate all of that, we will probably be sending you out the self-evaluation and the skills matrix in advance of the March board meeting with a request that they be returned anonymously in postage self-addressed postage prepaid envelopes. That will cut down on the time in the March board meeting that we will need to fill out some of these things. We'll likewise be sending out a series of mailings, one of which will be the policies, which tend to be voluminous and slow to work through, so that you have an ample amount of time, as we did last year early in March. And then finally, once the audit and the annual report are completed, which will be closer to the meeting, we'll try to get those out to the board as well, so that you'll have ample time to review those before the March board meeting. All of that will be considered, as it usually is, in a perfunctory way at the board meeting, with most of the work being done by the governance and audit committees. Thank you.
Thank you, Tony. On the policies, can we send those out on board effect? Is they're confidential, or do those need to be hard copies or links?
We usually email them to our board members. We could certainly put them both in email and in board effect, I'm guessing, right, Jeffra? That was a nod up and down by Jeffra. That's good.
Yeah. All righty. Thank you, Tony. Let's take 30 seconds and so we can disengage and then come back and we'll be in executive session. Okay.
Just waiting for confirmation. Okay, we're back.
Okay, so I think for the good of the order, unless there is anything else that we need to discuss, I would invite you all for our next meeting to send in your pictures of your dogs and cats and goldfish and
That's part of the meeting.
Whatever.
It's a good lesson, and be careful what your screensaver is.
Whatever.
I don't know, Jeffrey, I think that might have been the best looking board member we have, so.
There's, Jen, there's
Yeah,
no
we could have a
question
different
about it.
mascot for each meeting.
I think I heard the dog vote no.
Please try to remember that we are live online.
That's okay. Jeffrey, you made my day, so thank you. Thank you for that. But if you do have a nice picture of a fish or parrot or something, send them in, we'll put it on the agenda. Anyway, thank you all, as always, very much. Unless there is anything else we need to discuss, we are adjourned. Thank you, everybody.
Thank you, everybody.
Stay safe.
Thank you. Good night.
Take care, everyone.